Another exciting case in the space of endovascular aortic repair. Yeah, thank you. Yeah, so we are here now in this hybrid room with Michael Tierkowski, one of our interventionists here, and Professor Steiner. She is currently a guest doctor from Vienna, our hospital, and maybe Michael, you can introduce the case.
Yeah. Good morning, everybody. We are here with a 44-year-old male patient with a subacute type B dissection. As a risk factor, he has an arterial hypertension and he is an ongoing smoker. Next slide, please. He showed up at our hospital with a type B dissection 1 month ago, and he has still a poorly controlled arterial hypertension. He has some recurrent intermittent intermittent pain. And he also he showed up again 4 weeks after the initial CT angio. He complained about claudication, and here you can see the CT, the control CT after the first acute phase of the type B dissection with a very, very steep aortic arch. Maybe you can see it in the angle later how steep the arch is with the fourth lumen. And I cannot see the last picture. Yeah, the collapsing true lumen. Next slide, please. We are prepared everything. We are doing an all percutaneous approach. We preloaded probe lights on the right groin where we wanted to put in the graft. We are already set up for an IRIS controlling examination of the true lumen, and we want to implant this thoracic stent cup after right ventricular pacing.
Fine, very good. Yeah, thank you very much. So hopefully if you can get back once again to the CT, it appears to be not a too complex case, hopefully. So the dissection, can really see it here, starts around the subclavian artery left, so that's typical. And then we have an entry, let's say 2-3 centimeters more distal, at least on the CT. The narrowing, the true lumen is usually the very narrow one in the distal thoracic area, and what is new now with this patient is the claudication on the right side. So there has been maybe some changes also with the dissection membrane during the last weeks with the new onset now of the claudication. The hypertension is fully controlled, so you could maybe say it's a borderline case between uncomplicated and complicated. There is a little bit of ischemia on the right leg now, but also in line with the new data from the INSTEAD trial, we found it worthwhile to show once again the dissection. As you know, the data show that stenting is indeed better for chronic or subacute uncomplicated stenting than standard technique treatment medication. So, okay, so we are ready here to continue now with the angio. So what we do usually now is, although the graft has a diameter of 22 French, we do this percutaneously with 2 probe lights preloaded here in the groin. That has done this already now. And these are typically young patients with not a lot of calcium here in the groin, so this works actually quite nicely. And we have done also another angio. So first we went up here with our pigtail catheter. Just a moment, where is it? Yeah. So what we do to really find the true lumen with the catheter, we take a pigtail catheter, so we don't take the wire tip upwards, which can rather easily also go into the false lumen maybe. So we take a pigtail catheter which we push up, let's say with the loop, until we reach the distal artery. We give a shot, and here we can see that we are in the true lumen. We know from the CT that all distal arteries here come from the true lumen, and then we continue to push the pigtail up without wire. I think here this technique gives you the highest chance to remain in the true lumen. You can, of course, check this with transesophageal echo. We have here now an iris. Maybe we can switch to the iris. We have loaded here also a stiff wire, a lumbricus wire, and here you can see now the iris. This is the volcano system. So we go back here this is the brachiocephalic trunk. No dissection here. This is the left common carotid, also no dissection here. And here is the subclavian artery. and just distal to this, the dissection, as you can see here, starts, as we have seen on CT, and if I go further down, you can see here that this lumen gets more narrow, so that's what we have seen on CT, that the true lumen is the small one, so we are right here, and when I go further down here, just a moment, this should be the trunk. So what's also very visible here, Anrej, is really the dynamic component of this disease. So you can see the membrane moving, kind of a consistent with the blood flow into the fourth lumen. So that's actually also the intention, that where we want to change the situation by implanting the stent graft. Exactly. Here's the celiac trunk. Sorry, this was already the mesenteric artery. Go back once again. So celiac trunk here. Then I go further down. You can see here we have the true lumen again, mesenteric artery here. The left renal vein passes the aorta. Then sometimes it's very difficult to see the renal arteries on the right side. You can see the right renal artery is higher. Now this is not that clear at it changed the position. Now that's not, yeah, here, you saw it maybe here on the left side. Now at 6 o'clock, the left renal artery, that moved around the wire now. This, I would go further down here again, a very narrow lumen in the abdominal aorta. When I go here into the common iliac artery on the right side, you can see here this very narrow collapsed true lumen, and this fits to the claudication which this patient now feels. Fine, so we are absolutely right with the wire. And we have here a 14 French sheath to predilate the common artery. We measured something like 31 millimeter of aortic diameter right at the subclavian artery. So we oversizing should really not be a lot in dissection. Some do not oversize at all. Some recommend 10% oversizing, some 5% oversizing. So with 34 millimeters, we're really not too much. It's maybe something like 10%. We have, I would say, as it is typical for younger patients, relatively, Gothic arch. In these cases, maybe a little more oversizing might help to have a nice seal proximally.
So while you prepare for the graft insertion, we have Christoph Nienhaber here on the panel. Christoph, any thoughts regarding this case, indication, any remarks?
As Anrej already explained to the audience, this is a very nice case of a subacute dissection with evidence of complications lurking around, late bar perfusion, ongoing pain, untractable hypertension. All this is nowadays considered to be features of complication, and this is a well-selected patient for this intervention. The idea must be to realign the lamella, to reorganize the aorta, and basically reshape the initial true lumen. And with sealing this proximal large entry site, I think the patient had a fair chance to remodel his aorta and eventually have a stable long-term course. And the window, the time window that was picked in this case, I remember 4 weeks after the impact. Anrej, is that right?
Yes, it's 4 weeks after.
So that's right in the window of